We are privileged to welcome Dr. Anna Chodos. Dr. Anna Chodos is an associate professor of medicine in the Division of Internal Medicine and the Division of Geriatrics. Dr. Chodos is also the director of whole person geriatrics in the San Francisco Health Network, as well as the director of our outpatient geriatric consult service and the geriatric neurology cognitive clinic here at San Francisco General. Dr. Chodos has a wealth of expertise and experience providing geriatric care, and particularly to those who are living with HIV. And we're truly honored to have her here to share important insights on this topic. So thank you.
Thank you, Liz. You can hear me okay? And hello, everybody on the OWL. I look forward to hearing your questions. So thank you so much for the nice introduction, and good morning, everyone. I hope that today will be really just a practical discussion of some of the common issues we see in older adults in general. And I'll also mention, of course, why they're particularly important in people living with HIV. And very proud also to be here to just represent a wonderful partnership between the Golden Compass program and Ward 86 and our geriatrics division. You guys have always been extremely welcoming and inviting to our collaboration. I have other colleagues who are doing the clinical care in Ward 86, one of whom is gleefully on maternity leave, so we're very happy for her, but I'm actually representing her clinical care here today. I went through her cases and presenting the work that she's been doing clinically with you guys. So just very proud to be doing that, and really looking forward to the conversation. I just wanted to say we have this program called the Geriatrics Workforce Enhancement Program. That is how I get some funding to work more broadly with primary care in our network, including your clinic. And our mission, I would say, is to support the primary care workforce to do more, to feel more competent, have more skills to work with our older adults who are coming through primary care. So for us, we just want to be a resource. And oh, sorry, I felt like Siri was talking to me. She does that sometimes. We just reapplied with the support of Ward 86 to do another 5 years of work together. So I just wanted to shout out the GWEP as a resource that we're trying to bring to the network overall, but particularly Ward 86. Sadly, no financial disclosures. Our objectives today, we're going to try to understand some of the common geriatric syndromes that older adults are living with, and maybe more disproportionately affecting older adults living with HIV. So I'm going to touch on the issue of cognitive impairment, hearing loss, and falls today. So get ready to have wonderful things to talk about at your upcoming cocktail parties this weekend. Very interesting all around. And I really am just hoping that as we're learning together today, that you feel like you have tools in your toolbox to help improve just routine care for older adults living with HIV. And also that you feel that you leave here with one resource or one way that you can make their lives better. I'm not focusing today, I just want to be clear, on community resources, organizations, which are obviously critical to overall health, really more clinical resources. And maybe honestly, if you just leave here with my email, that counts as well. Okay, so we are going to do some quizzes. So what do you think the prevalence of, I probably should have put it in quotation marks, cognitive impairment in older adults living with HIV. So if everybody knows how to log in. Okay. Great, so roughly 20%, possibly as high as 50%. Oh, this is exciting. And less traumatic than watching like the polls. And okay, and what do we mean by cognitive impairment? So these are all good questions because I think there's this phenomenon, I would say, with cognitive impairment, maybe other terms we've heard like dementia, that honestly, once we start talking about it, dealing with it, everyone around seems to have symptoms as well, meaning it's a confusing topic. We don't have a lot of clarity clinically, I think. And there's a lot of research definitions, I would say, that are out there, particularly in the world of HIV-associated neurocognitive disorders, that makes it kind of hard just to have like a off-the-cuff prevalence. But we'll keep talking about this and you will get your answer. But we'll start with a case. So this is a case Their initials are JE, 62-year-old man who's here for routine PCP. This is their HIV. Can you see the? Okay, great. This is their HIV history and treatment. Very well controlled now on Biktarvy. But historically had some difficulty with adherence. I also wanted to say I peppered in the case presentations just general information about these cases, not necessarily all relevant, just to give us a sense of the person. And also, no one in any of these cases is cured, nothing is solved. And for some of them, we don't even totally have answers. We're just going on these clinical journeys with them so we can learn some clinical care. This person also has had a history of lack of housing, is now housed, has had substance use disorder, and mental health conditions, sort of not a formal diagnosis in the chart that I could find, but on a long-acting antipsychotic for psychosis. And this person's very excited about going to a family reunion in Arkansas, has been on testosterone therapy for hypogonadism and symptomatic low energy, and then also complaining of a lot of sleep symptoms, interrupting sleep, but without any real collateral history about what those sleep symptoms are, and has been unsuccessful in getting a sleep study done. This is my entire life in geriatrics, is like not being able to get the sleep study actually done in a way that's helpful. So I felt I really identified with this concern in the chart. And then the case manager is coming with the patient today and noticing that this gentleman has multiple changes that are new in the last year or so, or at least since they've known them. Their affect is more flat, they're making less eye contact, and their speech appears to be slower. There's multiple notes in the chart that they have a care provider, but it's unclear what the actual functional needs are. But just to say that there's some evidence of functional impairment. When asking about trying to get more history on what's going on with their sort of presentation changes, the patient is saying they're not using drugs at this time and a UTOX is negative, but they are more socially isolated. And then a neuroexam was performed and was essentially normal. And they had this test called a Montreal Cognitive Assessment, and the score was 23 out of 30. Technically, normal is 26 or above. This test, abnormal, means it could be either a mild cognitive impairment or as far as a dementia or something like that. So it's a highly sensitive test for anything going on. So what I'm trying to say is a lot of people are abnormal because it tries to capture as many as possible who might have something going on. Does anybody know the MoCA? And so it's also kind of a long and it's kind of a hard test. So very impressed that people do this when they do it in primary care, because it's kind of hard to get done. It's just really long. And if people are having trouble, it can take as long as 30 minutes, even though it's really designed to take about 7 or 8. When seen in the Golden Compass, so that was the PCP visit. When seen in the Golden Compass clinic, this gentleman was actually intermittently drooling during the exam, was noticeably extremely hard of hearing, and on further exam had a lot of earwax, so rumen impaction in the ears. And a further functional history noted that actually he needed a lot of help with what we call instrumental activities of daily living. So the more complicated, I'm independent in the community tasks. And with basic, I need to be independent in my home tasks, like can I bathe, get dressed, and toilet. I know bathing and dressing can be somewhat optional, but like big picture, if you can't do those things at all, eventually you need some assistance. And this person was actually referred because of sort of the neurological picture of the slower movements and less productive speech and the drooling, to what we call our geriatrics neurology clinic, essentially a dementia clinic. And there he had more extensive neurologic and neuropsychological testing. And his picture on the neuropsych testing, which is more like an hour long, can be 2 or 3 hours long. We try to keep it to an hour and really focus on things that might be related to a neurodegenerative process as opposed to an autism or some other developmental cognitive process. But he was deemed to have what's called fronto-subcortical deficits, meaning that his executive functioning, some learning and retrieval, so elements of memory, but also just getting information in were impaired. And also difficulty with confrontational naming. That's things like, what is this? What is this? Holding up objects and seeing if they can come up with the names. And then also motor and psychomotor slowing. So maybe a lot slower to draw or finish a puzzle, things like that. And those are all features that are very common in and would be more typical of an HIV-associated neurocognitive disorder. Also had imaging just to further round out the workup, which really showed more nuclear atrophy. So if you have somebody with an Alzheimer's type picture or a Lewy body, or what Wendy Williams was just diagnosed with, a frontotemporal, you would see patterns of atrophy, so actual tissue loss. But he didn't appear to have that, but he does have what's called microvascular disease, so evidence of essentially small strokes over a lifetime. And was diagnosed in that visit with major neurocognitive disorder. That is the new improved name for dementia, due possibly to HIV-associated neurocognitive disease, plus some vascular changes because of this imaging finding, and maybe medication effect. And it was noted to consider CSF studies to see if there was active HIV in his CSF. It was not in his bloodstream, as I mentioned earlier, and definitely consider decreasing the medication. So this is where partly I wanted to mention we don't have the full workup. This was only a couple months ago. He's not had any CSF studies that I can report back to you. But Golden Compass, when they saw him again, decided to help with the dose reduction in coordination with psychiatry on his antipsychotic, which was a long-acting, which was helping him a lot with his symptoms of his psychosis, but possibly now having these serious side effects. And this is our one of our key interventions, ear lavage, to get the earwax out and to see if his hearing was improved, and to consider audiology referral. The other big thing was to coordinate with and really encourage home health. So this is a service where a skilled nurse, a skilled physical therapist will go out, and they can also bring occupational therapy, social work, a home health aide to help with the practical aspects of managing a condition like this, and helping him with independence. And his independence with OT, like 5 or 6 OT sessions, actually did improve, and he was able to do more for himself around bathing. The issue of sleep hygiene is still there, and he got some earplugs, I guess, after we took out his natural earplugs, but he got additional earplugs to help him with any noise and sleep interruption there, trying to still get the sleep steady, sort of a hopeful, optimistic sentence there. And then continuing to manage all these other factors. So vascular risk factors and physical and social activity are really, really key to brain health. And these are, it's sort of like obvious basic stuff of life that doesn't get necessarily super exciting to encourage in a medical clinic. And obviously there's no pill for these things, but these are, if you leave here today with nothing else, the physical and social activity are really the absolute sort of bedrock of brain health. So this, I think what we're seeing here is sometimes when people are having new cognitive issues, and that wasn't his primary complaint per se, the case manager had really put this on a personality or, kind of affect change. But this is sort of where you see the cognition, the rubber meeting the road. So that functional impairment can sometimes be a major tip-off if we're sort of focused on other aspects of their presentation. I'll just say behavior is a cognitive function. So in the sort of dementia space, we discuss behavior a lot as just another cognitive domain. But obviously in folks with serious mental illness or other behavioral health conditions that are either optimally or not optimally treated, it could be primarily psychiatric, of course, but we always think of this, especially in older adults, as a potential sign of a primary neurodegenerative or neurological process. So some clues there. But I think when I've looked at what is really the prevalence of cognitive impairment, or let's go further and say mild cognitive impairment, what's now minor neurocognitive disorder, or further even and say dementia in people who are living with HIV, honestly, there's just kind of data all over the place. And I guess the question would be, what for us in primary care is really helpful to know? How would we know what to look for and how to move forward? As these criteria are getting further refined and further sort of established to help us understand what's the real prevalence of all these conditions. And I always look back to Dr. Meredith Green, who moved on from here and did a study in 2015, or at least published it in 2015, where she looked at patients here in San Francisco, older men living with HIV, mostly older men, and looked at their geriatric syndromes. And folks living with HIV 50 and older were included in this cohort overall, but with the median age of 57, had very overall prominent and frequent geriatric syndromes, what we might see in a general population across the US, more on the average age of 75. And on this particular instrument, the Montreal Cognitive Assessment, which I already alluded to, is kind of hard, meaning it's really biased towards people who have at least a high school education or more. 47% had an abnormal score. So is it, are we really thinking that half of older adults living with HIV do have a significant cognitive impairment? I think it's where the significant piece, that's where we come in as clinicians and as practical thinkers to help people. But it's clearly very prevalent. And so something that I've noticed everyone here seems to be doing a great job of picking up on. And I know us as geriatrics colleagues would really love to continue to support and help out with. I just want to draw some parallels between what the categories you see in the literature are for HIV-associated neurocognitive disorders, together known as HAND, and like good old-fashioned regular syndrome dementia. It's really the function that starts to separate people out, and then these sort of preclinical or unclear clinical areas of there's some impairment on testing, but there's just no identified functional impairment. And I think sometimes a lot of us clinically wonder, how good is that test for that person? Because the brain in all its wonderful complexity, we don't necessarily have the same precise instruments for every single type of brain that we do for other conditions. Like, measuring a thyroid, a TSH hormone, is relatively unaffected by education level, language, cultural background. Have they ever taken a test like this before in their entire life? Race, ethnicity. But in dementia, the tools we have, or in assessing cognitive impairment, are really affected by those things. And are we always really well matching the test with the person? But in any case, the categories that these are really used for research mostly, are asymptomatic neurocognitive impairment, where there's no impairment, but a degree of impairment on testing, I would say, in at least 2 cognitive domains. The next mildest, which would be mild neurocognitive impairment, where there's maybe a mild impairment of function and a mild impairment in 2 cognitive domains. And then HIV-associated dementia, where someone like the person we just met in the case is really having day-to-day, quite noticeable challenges with function and really needs support from another individual most days. And the features, when I see clinically us trying to think through, is this more related to HIV disease, or is it more related to a different process? Because the wonderful thing about older adults is they now can have multiple things going on. Occam's razor has been thrown in the garbage. Nobody's using it. And we're trying to, as I know you guys do with your incredibly complex patients. But what really would tip us off that this may be more related to their HIV? And a lot of maybe the same findings that you think of with more standard, like an Alzheimer's disease, where memory loss is really prominent, concentration is difficult. There's some aspect of cognitive slowing and difficulty with comprehension, but it's really the motor pieces that start to also be more symptomatic in a hand type picture, where there's difficulty with coordination, gait, there might even be a tremor present. And as I mentioned before, behavior really all of these honestly could be stuck in as cognition or cognitive domains, but in the behavior category, things like depression, mania, and apathy may be more common. Then, as I mentioned, other types of dementia. So now I'm just going to give you a quick review of regular old dementia, which affects many, many older adults as well. So if you're willing to participate with me, the question right now is, how many people 65 and older in the US, sorry, I should have said that, have Alzheimer's disease? And I gave you both a percent and a total number. Okay, let's go to our live polling stage. Okay, roughly 5%, roughly 10%, 20%. So when averaged over the entire population, it's about this year, roughly 6.7 million, 6.5 million was one option I gave us. So about 10% of the general population over 65. In Medi-Cal in California, it's looking like our older adults who are on Medi-Cal, it's looking more like 20%. There's a higher prevalence in people who identify as Black or Latinx as well. So there's a lot of sort of subpopulation and disparities considerations. Women over a lifetime are also far more likely to live with dementia than men, about twice as likely as well. But when we smush it all together, it's about 10%. And then the big issue in geriatrics, of course, is it's very, very age associated. It's the biggest risk factor, non-modifiable as of yet. And, my rule of thumb, and this is I would argue, very healthy, or I would say generalized population, but in the 70s, maybe more in the 5 to 10% range, people in their 80s, more in the 15 to 20% range. And then once people are 85 and above, I usually say 1 in 3 and sometimes 1 in 2, depending on the population you're serving. So very, very common. This for me is, and also the disparities issues are a wonderful reason to consider just screening everybody who's older in primary care. I just wanted to share with you sort of the similarities with the hand in terms of just general dementia diagnosis. And if you leave here with nothing, really, I think the big pieces are cognition, function. For all my primary care patients, do I have some sense of if they've had any cognitive changes and if they've had any functional changes or decline? And what have those been? How can I support them? Is there any way that this would be possibly tied to a dementia or neurocognitive disorder, as we're saying now? I think a big question, maybe even comes up in the New York Times, I don't know, don't have time to read it these days. Is age-related decline, what's normal? What should we be expecting of older people? I'll just put it out there, all change is the only constant, all of our organs are changing, absolutely, the brain changes. In some ways it gets better, in some ways it is, from our perspective, more challenged. So normal things can be a little slower recalling, more word-finding difficulty, not as able to multitask. But typically, this is not affecting daily function. You're doing all the things you've always been doing. And that would include things like bills, arranging a trip, a shopping trip to get groceries. Yes, the brain is going to change. We call it mild neurocognitive disorder, or what used to be MCI. Again, similar to the mild HIV-associated neurocognitive decline as well. If there really are abnormalities in the cognitive functions that we're detecting on testing, or often just in symptoms. So how do you know if it's abnormal? We've all had a cognitive moment where, oops, I locked my keys in the car. I forgot this. Oh my God, I was supposed to be at Grand Rounds and I totally forgot. Whatever it is, things happen. Our brain can't handle everything. I start to think what we really need to think of is severity and trajectory. So if people are starting to have that symptom more and more often, and it's more and more noticeable or more and more serious, like, okay, I forgot to pick up the grandkids like 3 times this week, whereas last year I forgot once when I was also planning a big party the weekend, whatever it is. So I think those are good rules of thumb when you yourself or your friends or your family are starting to worry. Is this normal? Is this not? How serious is it? And is it getting worse over time? And then the functional stuff is really, I kind of showed you how we think of function, and geriatrics is all about the F word, function. What are the changes that people are noticing in their ability to do daily activities of daily living? And that's really how we sort clinically significant major neurocognitive disorder from mild. And there is, of course, the connection here, the assumption that this is a preclinical syndrome of this. but age-related decline really is not in the pathologized or pathological terrain. And just a reminder that this is the definition of dementia is from the DSM. It's a syndrome. So once we've recognized the syndrome of a cognitive decline and a functional decline, we're still in the realm of, well, what's causing it? And that's where folks that we get to see that you guys refer to us, you know, HIV associated neurocognitive disorder might be on the list of things that are causing this syndrome. So in my view, you know, the important thing is just to recognize that this syndrome's going on, and then we have time and we have resources to try to figure out what might be the underlying cause. And in some people, we may never figure out. But is it valuable? Isn't it valuable? I welcome your thoughts on this, to identify the syndrome at least, even if sometimes we don't know the underlying condition. Because I think this is what, as diagnosticians, as clinicians, hinders us, as we feel like if we can't nail down exactly what's causing it, then we don't want to recognize it at all, or we feel funny about that. And I want to offer that I think it's still valuable to us as clinicians and to patients and their support systems to still find it. In the general population, the causes, still the big man on campus is Alzheimer's as the main cause of dementia syndrome. Vascular disease is often co-occurring or can be the primary cause. Something called Lewy body, and as our celebrities are aging, I'm having more and more examples of people who have these conditions, but unfortunately, Robin Williams had Lewy body dementia, and he died from that. And his primary presentation was not memory. He was working on a movie set at the time, but it was really his behavior and sleep disturbance. He had severe sleep disturbance and what you'd call more behavioral or psychiatric features. And then frontal temporal, as I mentioned, both Wendy Williams and Bruce Willis came out as having this diagnosis in the last few years. And both of them presented with aphasia first. So not memory or other symptoms, but with inability to express themselves verbally. So we do have tools, just, you know, again, when we look at the case we went over, it was terrific. You know, the PCP recognized that something was going on and had resources around them to refer to geriatrics. So, you know, no problem there. And that person quickly got into dementia clinic. But in general, how do we approach a screening for people? And this is a general population recommendation, but in general, the tools apply. So dementiacareware.org is a resource for you guys. If you're like, maybe I could incorporate more screening for dementia. Really, you can start with a brief history, just a single question. Have you noticed any changes? And then we offer really quick screening tools. We don't recommend the MOCA because honestly, it's too long for primary care. So we recommend like a mini COG, which is a 1 to 2 minute test and a review of function. And actually, there are tools you can hand to an informant, meaning I could screen my patient. It feels weird, but I could screen my patient by giving 2 pieces of paper to an informant. Like a informant sounds funny all of a sudden, but someone who has information and knows the person can fill out a survey like about cognitive symptoms and functional symptoms. And those are validated tools for dementia in your patient or for, positive screen. And then we really advocate starting to understand that person's support system, which honestly, you guys are fabulous at. But documenting and asking about, do they have anybody in their life who provides support, or do they even have a documented surrogate decision maker? Often the answer is no. But that's why we're starting the process now, because it's a foundational piece of being able to care for people who are having these symptoms, right? For our first patient, that case manager, the caregiver that's supporting them day to day is crucial to know about, crucial to document. So again, as you leave here today, enriched with knowledge, the main thing is I always keep it in three pieces. What's their cognition? What's their function? What's their support system? And I use that for screening, diagnosis, and management. So now I did a screen and I found some signal. Now I'm going to go next and dive deeper into each of those areas and figure out how they're being affected. What's the detail of those symptoms? What data can I get? What additional objective information? And then as I'm managing it, I want to find ways to support their cognition, function, and support system too. So I just sort of stick to this 3-part model. And this cognitive health assessment is one way to start the screening process and start on sort of those 3 pathways. and knowing that it's gonna take a while, and that's okay. Often these things are not urgent. The other thing is general brain health rules, as you saw in the Golden Compass note, apply to everyone. And you don't need a diagnosis to start these aspects of care. So this could be a preventive health, public health approach. Frankly, we're not quite there yet. But the biggest modifiable risk factor for cognitive decline, as you're going to hear me blather on about later as well, is hearing loss. The other biggest one is early life education. So unfortunately, I'm at a point often meeting people where I can't affect that. But in lieu of being able to change policy and practice on getting everyone excellent and public early education, we can affect hearing and vision. So it accelerates cognitive decline, and it also is a risk factor for developing dementia to not be able to hear. Vision, we just don't struggle as much getting people to correct their vision, but it is important that people can see as well. Medications and frankly, what we do to people is also really important to consider, and that we're not prescribing them things that cognitively affect them. Social and physical activity, again, some of the only magic pills we have, and so important to help people find and connect to resources for that. And then this part is, again, something I don't really need to support primary care to do. Everyone's pretty fabulous at managing blood pressure and diabetes within goals. The other reason, and this is increasingly in the news, and I would say pressure on the dementia clinical community, is new therapies are emerging. That's a really new thing in general for dementia. There's not been new therapies in a very, very long time. But the therapies that are being developed for Alzheimer's disease and the way we're going to diagnose it are rapidly changing. So things like amyloid-specific PET imaging, biomarkers that are highly accurate for, is there amyloid protein that's also in the brain? These things are going to be more and more readily available and will help us separate people who have a big burden of amyloid from big burden of people from those who don't. Unclear if all those people actually are going to develop dementia. That's a whole other, and like clinical Alzheimer's disease. So that's an important consideration. But just to say, it's going to be kind of in the milieu, and we're going to have to incorporate this into clinical care, hopefully to good effect for patients. And the other thing is, last January, they published a study of a monoclonal antibody that clears out amyloid protein from the brain called lecanemab. It was approved. It's being given. It's an infusion you have to do every 2 weeks for roughly 18 months at this point. And it just wipes out amyloid in the brain. It's very, very effective at cleaning that brain. It also has some very serious side effects, understandably, like 20% of people will get brain hemorrhage or edema. So, very serious medication. But probably the biggest issue with this medication is it has to be given extremely early. So you have to be essentially preclinical or extremely mild disease. And we don't detect people at that stage because we don't screen and we don't really know who has Alzheimer's disease that early. We also, they had about 18 months of follow-up, and people progressed more slowly, but they did not progress at all, who got the drug. So lots and lots of questions about, this medication. We do not have it here. UCSF is doing it at the Memory and Aging Center. It is not clear. I've not seen anybody who's living with HIV get this medication. They were excluded from the original trials, but will be interesting to see if our people have Alzheimer's and HIV, if, presumably they should be able to get this medication if it's indicated and of interest to them. But just to point out, this may be another argument that is compelling to health systems to detect early if we can really change the course. And it may be very compelling to patients and caregivers. And so I think there's also compelling reasons just simply within people living with HIV who have hand or something on the spectrum of, HIV related neurocognitive disorder. One would be, continuing to address their antiretroviral therapy and making sure that's adequate. Treating underlying comorbidities always tends to help the brain, as I already mentioned. So these are general care recommendations. But again, the thing that keeps me really engaged with trying to move detection earlier and supporting people with these conditions earlier is just, frankly, patients and caregivers tend to say that their course with the disease goes a lot better if they knew they had it in the first place and were able to plan. I'm about to conclude my discussion of the cognitive issues and our first case. Does anybody have any questions? Yes, sir.
I think you referred to this already, but do you have a favorite alternative to the mocha?
So, oh yes, so repeating the question, do I have a favorite alternative to the mocha? Honestly, I just don't use it as the initial screen. If people have symptoms or a positive mini cog, I tend to use the mini cog. You'll see on our website, there's something called the GP cog as well. It's like a mini cog with a couple extra things. So I would use that for screening, and then to get more information in depth about their cognitive abilities, I do use the MoCA Live. They have a high school education, and particularly if Western educated. If not, there's something called the MoCA Basic. And the thing about the MoCA that everybody should know is right now, they're trying to get everybody to take a training. So you have to register on the website. You have to do a training. The reason is it's actually a hard test to administer, not just to take, but to administer. You can really, in my view, make it just a much harder test if you don't like read their instructions. But the MoCA Basic you can use with folks who can't read or write and have essentially an elementary school education. And then there are things that are also pretty accessible, like the SLUMS, terrible name, but it was St. Louis University VA Medical Center. It's a lot like the MMSE, so that is one that tends to trend towards Alzheimer's. And then I hate to totally cop out, but my friendly local neuropsychologist. So we have batteries for, just so you know, in our dementia clinic, we have batteries that we've developed for different languages. And for different education levels. So we really try to tailor it a little more culturally, linguistically, and education-wise. Okay, another question?
Yeah, just for clarification, so is the thought that hearing is that due to like isolation?
That's such a good question. And I'm going to say a little bit about it, more about it in the next section. We don't know. There's different thoughts and nothing particularly proven about why loss of sensory abilities are, but isolation is clearly a contributing factor because it, makes people reduce their social activity as well. The brain's definitely a use it or lose it organ in that regard. They actually think it really heightens cognitive load because you can't understand what people are saying. You're actually trying a lot harder and putting more strain on the brain to just get through a day. So that's another reason. And then there's just, especially with things like memory loss and hearing impairment, it's like, well, did you hear it in the first place? There's a lot of just lost information. The other thing about hearing loss, okay, we can just get to hearing loss. Is there another, I'll get to that in the next section.
There's 2 questions from the chat.
Oh, sure.
One was, in case 1, was that drilling indicative of Parkinson's disease?
Yes, all those symptoms were labeled as Parkinsonism, thought potentially due to med side effect. Thank you for giving me the opportunity to clarify.
Great. And then the second is in similar vibe, I'd say the question, do we have any data regarding impact of HIV itself versus socioeconomic disparities and modifiable risk factors in the development of hand?
Yes, so I know that there is, and I'm definitely not an expert, and I would, so I'll keep it short. I know that there's definitely evidence that, HIV infection can have direct impact on, brain health and neurologic health and integrity of cells and inflammation in the brain. So there is in folks who, for example, have escape in the CNS or, have a history, as this gentleman did have some history of non-adherence over a lifetime of just, not well-controlled HIV. There is some direct effect, but you're right. It does appear that socioeconomic, early education, these are all some of the strongest impacts on brain health overall, and what essentially amounts to a reserve of cognitive health that then in later life gets more and more taxed. So sort of the higher SES, higher education in particular, really builds this cognitive reserve. So we have a lot of high reserve brains in the room today. Yes. Yes.
So the suggestion to screen yearly from age 65 up with HIV accelerating some comorbidity, wouldn't you want to do that earlier than 65?
Yes, you made the perfect clarification. Question was, don't we want to start screening then earlier in 50 in the age 50 and up in people living with HIV? And my answer would be yes. And sorry, I did not make a more clear point about that. Thank you.
Thank you. Let's move on. Yeah.
Okay, we're going to move on to the next one. So this quiz is the top reason for emergency department visits related to injuries by cause of injury in 2017. And all of these, yes, are monitored and measured, including hot objects. So was it motor vehicle, cuts, falls, bites, poisoning, hot objects? You guys you read the room. Yes, it's falls. And it used to be motor vehicle accidents and in different urban centers, trauma, emergency rooms. But many, many counties have contacted us and let us know that their most common trauma patient is an older person who fell at this point. So just really quick, I just wanted to point out that I have noticed in Ward 86 PCP notes, the attention to osteoporosis is second to none. It's amazing. You guys are all over bone health. I totally understand why. There's many contributors to low bone mass in people living with HIV, and I have nothing to contribute on this topic. I just wanted to commend you. But I'm wondering, I always think of it as a two-sided coin, falls and low bone mass, so, and bone mineral density. So if we're thinking about osteoporosis, we have to be thinking about falls, at least in the older adult population. And so I also wanted to say that, when we look at the ED visits, it's not like a close competition. Falls is really a major trauma factor for, the whole population, but specifically with older adults as a really major life-altering event. And I just wanted to say, if it's just one fall, how serious to take it? Can I follow up another time? And the thing, if nothing else, again, if you're seeing someone who's falling, the things that are associated with another serious fall with a fracture in people living with HIV, just as it is in the general population, is having had a fall. I know it's like extremely obvious. But just to point out, if you have someone you're seeing and they've had a recent fall, this is a high risk person for another fall and a fracture. So Mr. WS is 77. He also has dementia. We're going to kind of skip over that, and has depression, lumbar spine disease with chronic back pain that he gets injections for. He's had bilateral hip replacements, and he has one of his main issues has been a history of falls. I'm going to let your eyes enjoy the medication list here and run over these wonderful medications. But what's so interesting is when I was looking at his falls, like all over his chart, he's a faller, he's having serious falls. He's been in the ER for a fall. He's like, he's not just falling, he's like completely collapsing and falling down and hypersomnolent and confused. And this was in the context of some psychiatric symptoms probably related to his depression and his dementia, that he was prescribed an antipsychotic, aripiprazole, and afterwards also, like our other gentleman, developed Parkinsonism type symptoms of increased tone and tremor, but was really hypersomnolent on exam repeatedly in a lot of the notes. He was also on other medications that can cause hypersomnolence, like oxycodone and gabapentin. He was seeing neurology for the Parkinsonism. And over, the group of primary care neurology started stopping his medications. And they, because of his cognitive symptoms earlier, had gotten imaging that also showed atrophy, which is not always typical of hand. So there was some consideration of additional neurodegenerative disease like Alzheimer's or Parkinson's or something like that. Just to point out, so they'd gotten these other meds off, but he's also on fluoxetine, mirtazapine, doxepin, bupropion, buspirone. These are all things that can get in the brain. And he is being treated and taking calcium, vitamin D, and alendronate for his his low bone mineral density, osteoporosis. On exam, he did still have symptoms and examples of Parkinsonism, including dysphagia like the other gentleman, and constipation was a symptom. Just some flavor, some texture to this man's life. He was still doing exercises, going for walks. So I think even with a lot of clearly symptomatic Parkinsonism. But remember, we sort of discussed apathy as one symptom of hand. There's some sort of suggestion of that he really, really loves to do art, but kind of can't motivate to do it. And isn't interested in group activities as a socialization strategy. Neurology, when they saw him, thought that this could actually be, despite all the medications, but in part related to some of the imaging findings, thought there might be some element of Lewy body disease or Parkinson's. They're very related clinically, can look very similar, and wanted to trial Cinemet. So that can, and people who are falling with Parkinson's, that can be a great intervention. It can really help with stability and balance. When Geriatric saw him, of course, we cogitated and saw everything as possibly falls and put it in that framework, and further recommended stopping more medications. And this is the main take home, is just that medications with anticholinergic properties can adversely affect cognition and also affect fall risk. So the doxepin here was noted as an anticholinergic, has anticholinergic properties and could be additionally deliriogenic, cognitively impairing, and affecting mood, insomnia, and I would add balance. Also, fluoxetine can have some anticholinergic properties, could possibly consider another SSRI, not the strongest in the world, but just on the list. And then noting also that this person is on a supplement that they reported for memory that the geriatrician recommended to them. Maybe that's not needed. And a big lesson here is anything in geriatrics, our general principles, anything that's not helping is only hanging out, waiting to cause harm. And in falls, people who are falling, we find that any medication over 5 is dose related. It doesn't matter what the medication is. Could be Senna, could be gummy vitamin, is potentially, it's like sort of dose response, increased risk of falls. And then she also noted just keeping an eye on his treatment for osteoporosis. So quick review, just when you're seeing folks who are falling and realizing that this is potentially an important aspect of their care, which medications are sort of the highest risk? And really, polypharmacy is sort of the biggest risk, and defined as 4 or more medications, like literally impossible to get anyone under 4 medications, I know. But anything you can do to simplify, if it's not needed, it's not needed, is I guess just what I would say. Opioids, antidepressants, antiepileptics, antipsychotics, sleeping pills, and diuretics are also on the list. Of course, everything is risk benefit. If people need something, they need something. But the other principle would be, can we dose reduce? Can we harm reduce in that regard? The other thing to think about with your older adults, and I know you guys are rich with pharmacists, so maybe we can do this with passing mention, but the anticholinergic burden is something we do for all our folks as well because of the risk of cognitive decline and falls with high anticholinergic burden. The other thing, there's a lot of medications that have anticholinergic properties that you wouldn't know. So that's another really useful reason for the anticholinergic burden. And then there are studies with like a lot of midlife exposure to anticholinergics, higher risk of dementia later on as well. And then I think I've mentioned this before in this room. There's something called STEADY that the CDC puts out, and this makes it really, really easy. Everything geriatric is multifactorial, so we always have to have a list of things we're trying. We can't get everything done usually, but what things can we get done? And so for you guys recognizing if there's someone who's falling, assessing their risk factors, here we have gait and strength, medications, which I've just talked your ear off about, home health hazards, that can be a home health referral, orthostatic blood pressure, visual acuity, footwear. It can be cute, it just has to be stable. Vitamin D intake and comorbidities, and then how to intervene. And this just makes it really, I think, accessible, like just continually available to us as a resource and as a sort of a template. Okay, and I know we are at 10 minutes, so we're going to move on to the next one unless we have burning questions about falls. And this gentleman is in the process of getting all his meds reduced. Yes.
Mentions I've seen men. I mean, I realize it probably depends on the patient.
Oh, yes. So all of these are evidence-based, and I will just say the one that is kind of not popping out here. So gait and balance training actually can be really helpful if people are up for it. And the one that is just the heavy hitter out there, it's, you know, low key profile, but actually very effective and evidence-based now in like 4 different robust studies, is Tai Chi. And the goal is really balance training and strength training. And the strength is really about the hips and lower extremity strength. So another one, which is really simple, is that one of our gait tests is to sit down and stand up without using your arms. And if people can't do that, they can use that as actually a training exercise to increase hip strength, as long as they're not using a chair with wheels, or you want a stable chair. Did you have a quick question? Yeah.
Sorry, thank you. Something I struggle with in my clinical practice, especially in light of the polypharmacy, is bisphosphonates and how to balance bisphosphonates, which are often challenging for our patients to take, versus the low bone mineral density. And I was curious, and I feel like referring for Zometa is also kind of challenging for our patient population. Curious how you approach that.
Yeah, just getting people to take bisphosphonates, I think, is that the main question, or how to manage that if they don't want to take it? I think it's okay to look at other non-bisphosphonates osteoporosis meds, and like the IV zoledronic acid once a year, or other medications. Sometimes endocrine can help come up with a regimen that helps if it's really, yeah, they are a pain to take and can be really uncomfortable. So that would be is that helpful? Okay. All right, we're going to do hearing loss really quick. Hearing loss is like, because we've already talked about it a bunch of times, hearing loss is less likely to be corrected in older versus younger people. True or false? True. Yeah. So older people, they don't like to correct their hearing, and there's a lot of reasons for that. So our case is a 64-year-old man. He's reporting bothersome hearing loss. It's bilateral. It's not one ear worse than the other. Can't hear well, especially if there's a lot of background noise. Also has tinnitus, using lip reading strategies, tough in the masked environments, but has not had any hearing aids as of yet. Also has vision loss, osteoporosis, treated over 20 years ago, but not a full treatment. Can't afford the supplements for calcium, vitamin D, is doing daily exercise, and uses daily marijuana, lives alone, but has a partner that lives in the same building, separate unit, no mobility or functional concerns, no falls, independent functionally, and on exam, very hard of hearing, but uses a pocket talker in the clinic. I know we're definitely a broken record on this one, but in the Golden Compass Clinic, we'll focus on the hearing impairment. Seems like he probably has sensorineural hearing loss. That's, you know, as with all their things, some things degrade with age. The ears and the hearing is definitely a very noticeable one. Also with the tinnitus, which can be really, or however you prefer to pronounce that. For some reason, I've stuck with that pronunciation. But in clinic was doing really, really well with this particular pocket talker. And this is the one that we often sort of carry around or have in our shelves in clinic. And just to point out, it's $165, and that price hasn't really come down. And it's just a little microphone with headphones attached. And the person wears the headphones, and you speak, or you can put it on the table, but it helps amplify a direct conversation. This would be terrible, obviously, in a restaurant or at a play or something like that. But interestingly, despite his complaint, he wants to be the tinnitus to be addressed, but is declining a hearing aid evaluation, and is given information about how to get a pocket talker and other amplification options like over-the-counter hearing aids that are out there. And then seen in follow-up later, specifically about the hearing loss, he went ahead and purchased a cheaper pocket talker that he could afford, but it wasn't working as well. So he returned it and, wasn't using anything at that time. And then when talking more in depth about the hearing aid evaluation, not only was worried about, wasn't really interested, was also like, have you seen those things? They're tiny. I don't think I would be able to manage them, and I worry I'd lose them. And there's good reason to worry you lose them when they cost $1,000, $2,000 for a set on average. And that's pretty about as low as you get. So, the conversation kind of remained, this is where we are with a lot of folks, just keep harping on it and hoping they hear us about the importance of hearing correction and seeing how we can get them resources. But I just want to say, our instincts are very, very correct that people just don't use hearing aids. And even if they have significant hearing loss, and yet significant hearing loss is, in the moderate is incredibly prevalent, about 50% prevalent in people in their 80s and 90s. And this is at the level that it would really affect day-to-day life. And then the other big thing is they've now shown in this big cohort, these are people, the de novos didn't have any hearing loss, and we're giving education about hearing loss, but didn't, over the time period of the 3-year study, did not have any changes in cognition. But folks who did have hearing loss and got corrected had improved cognitive function with the hearing correction over time. So anyway, they were trying to prove, and they did, and I probably represented it really badly, that correcting hearing loss actually does improve cognition and help support cognition. So it's not just, it is actually both the risk factor and an intervention that we can undertake and help people. But the barriers, you guys know them. The cost is outsane. Even with these over-the-counter ones, most people still don't really know how to access them or use them. The fit is a big issue. The satisfaction with the sound. So the thing I tell people is, even if you get these fancy hearing aids, you're going to need to keep going back and get this adjusted. It's often not perfect right out of the gate. And then once they are good, they really love using them, I'll just say. Manipulating the device. I had one guy who came in every week just so we could change the batteries. Like, this was our medical intervention for him. He was a lovely guy. So it was totally, everybody loved seeing him. But the, these devices themselves are like designed for a different age group. And now, however, some of them are batteryless, thank goodness. The stigma is a huge issue. People really don't like to be identified as something with hearing loss. Okay, so I am happy to stick around, but I'll just go over the few take homes. That just consider in your own practice trying to detect cognitive impairment earlier, and just knowing that over time it really can affect daily functioning, as we saw, quality of life, and kind of regardless of whether it's HIV or now, as people are getting older, they're more at risk for Alzheimer's and other types of diseases that cause dementia. For falls, anticholinergic burden also helpful for cognitive impairment, but any polypharmacy and cholinergic burden can affect falls, so reducing that as much as possible, and any medication that's not needed. And then hearing loss, as I harped on repeatedly, is a major risk factor in midlife. So it's okay for us to go get our hearing tested as well, and but also especially for our patients. And I'm up for any ideas you have, any partnerships to improve our people's access to hearing correction. It's so important, and I really hope we can do a better job. There's one place that really does it totally for free, and they're like 4 hours away. ENT, I think, struggles just as much as we do in geriatrics to connect people to good devices that are affordable. And thank you so much. And I think we have 2 minutes for questions.
Thank you, Anna. That was fantastic. Learned a lot. We have a few questions in the chat. So one question was around what you've seen with COVID. So have you seen an impact on from COVID on the acceleration of cognitive disorders in this population, or not?
Yeah, I think there's definitely the well-described impact of COVID infection. I think the other big thing is just the withdrawal aspect, the social isolation that we've seen really one, I would say unmask some people's dementia, because a lot of, routine got upended, and then it was really clear that they were not, were just barely managing with the routine they had. And so I think there's sort of the two aspects of the direct COVID infection. I've definitely seen people who are now, very impaired cognitively from COVID infection would appear to be the main risk factor. And then also just from the break in routine, disconnection from services, the social isolation, and then the fear, with a lot of good reason. People were terrified of COVID, but then it has led to a lot of social isolation and agoraphobia, basically.
And then one more question. Can we use motivational interviewing to increase uptake for hearing aids?
Absolutely. I really try to point out how it can improve their lives with more access to connection. And for those who it motivates, like I really tried, with my parents, for example, to really talk to them about the cognitive impact. And I think for some people that's motivating. And I think for others, we need to be doing a better job of addressing the practical issue of the cost and the inconvenience because we don't have a hearing center here. Not that that would solve all the problems, but the additional trips to different organizations to try to get a hearing aid. And then people with VA benefits, whom you may have more of those patients than I do, sometimes they have good access to hearing aid support, which is good.
Just a quick question. I love the idea of Tai Chi as like a fall, intervention or prevention. How can we working with our patient population? Do you know of any programs? I mean, I see people doing Tai Chi in the park all the time. Can you just join them, or how does that work?
Yeah, SF Parks and Rec has great. Yeah, and I really encourage people to explore senior programs. I think the other one obviously is something that is otherwise sort of culturally and community appropriate. So a big resource. And one of the reasons I didn't overly emphasize community resources is I'm not the most knowledgeable for folks living with HIV specifically, but Open House SF is a great resource just in general for the LGBTQ+ community, and a great touch point, and can even connect people to other perhaps more appropriate or neighborhood resources. Yes.
First of all, thank you so much. That was really, really helpful. You started off with sleep, and we know that, and this problem of getting people into sleep studies, and we know the brain needs sleep. So I used to lecture people about sleep hygiene. It's not very effective way, but when I just started asking them about what they do before they go to sleep or when they go to sleep, you find out amazing things like, I always take some NyQuil. It's not a pill, it's liquid, so they don't count it. They won't tell you unless you ask. And then a shot of Jägermeister, and then I turn the TV on to the shopping channel, and then then I go to sleep. So there are probably things that we can do with that information, but that has a huge impact on a lot of our patients, I think.
I think that's a wonderful contribution. I have nothing to add.
On that, which is that people are so focused on sleep, which is totally appropriate, and that they need to get sleep, but then they say, well, I need a sleep aid to sleep. And then most of the sleep aids can be associated over time with an increased risk of dementia. And I feel like then patients are really frustrated when you say, well, I want you to do good sleep hygiene, but no, don't take Benadryl every night or take any of the things that you're taking every night. And they're like, what do I do? Are there sleep help?
Yeah, there's
places they can go or online resources, because I feel like this is just a constant conversation. It's totally understandable what people are like, well, then give me the pill and then I'll sleep and I'll feel great. Yeah.
Yeah, I always emphasize, of course, you could, and I would say on behalf of my colleague who will then be the one seeing them, especially if they're older, we can definitely make that argument. We are very, maybe used to nonstop saying that people need to, this is chemical sleep. This isn't actually good quality sleep. Also talking about the regular normal changes of sleep with age. So, and I know it's kind of obvious, right? Little kids, their sleep changes constantly, and we expect that. it actually continues to change throughout our life. And then as we get older, we have a lot lighter sleep, but it doesn't mean we're not getting those moments of restorative sleep, but it will mean we tend to wake up more often, and that may be okay. And just noticing whether or not you're actually tired, whether you give yourself enough time in bed to get enough restorative sleep. But anyway, pointing out that there's some normal changes, and that's okay. There's nothing to really do about that. Going all the way back over all the sleep hygiene stuff, I have so many people who do just like watch the TV for hours and hours at night, and it's on all night. And, that's like the bright lights that you don't need and are confusing your circadian rhythms. The amazing intervention that is like a small amount of additional exercise earlier in the day, bright lights earlier in the day in San Francisco. I know it's like a very rude suggestion to make, but sometimes you can get those like seasonal depression lights that tend to help regulate a lot. So we just walk through, you're going to think it's so silly, but in nursing homes in particular, adding lavender scent, things like a normal routine of like just like a wind down routine. And just, again, that motivational interviewing piece of like, well, what's worth it to you? What's important to you? What do you see here that's valuable to you about a routine that would help you get more natural, better sleep versus not? And I think it is a really, as someone who also doesn't sleep very well or give myself enough opportunity to sleep, I just do a little exercise where I'm like, I am so grateful for the sleep I did get. Even if I try to turn it into an appreciation of the rest I did get, even if it was instead of a singular focus on the rest I didn't get, and sharing my own struggles. But yeah, it's really, really hard. I would just say the way we've sort of, maybe for better or worse, very heavily moved away from like oxycodone and opioids, doing a similar thing with some of the sleep meds and just being clear, unfortunately, this is not going to help you. I wish it would, but and we're here to help. Thank you so much. I know we're a few minutes over. Really appreciate it.